Bismillahirrahmanirrahim. Now let's continue with our dermatology section of the pediatrics. So, in the dermatology, the very first topic that we are going to encounter is the congenital dermal melanocytosis, previously known as Mongolian spots. They present as benign, flat, blue-gray patches that are found in the infants over the lower back and buttocks due to the presence of melanocytes in the skin dermis. It is common in African, Asian, and Hispanics. Hyperpigmentation fades spontaneously. So, common pigmented lesions in the childhood. Right now, we are talking about this thing, congenital dermal melanosis, which is bluish gray patches, which are more common in Asian and African Americans. Cafe au lait spots, flat hyperpigmented patches associated with the McCune-Albright syndrome or neurofibromatosis, and congenital melanocytic nevus, like this one, benign melanocyte proliferation, increased density of the hair follicles. Okay. Then we have congenital melanocytic nevus, the one condition which is mentioned in this one. Uh, Benign proliferation of the melanocyte cells. It is solitary and hyperpigmented, overlying dark, coarse hairs. Risk of transformation into melanoma increases up to 5% with increasing size of congenital melanocytic nevus. Remove surgically if large to decrease the risk of transformation to melanoma. Small lesions can also be removed for cosmetic reasons. Scar injuries in child abuse. Scald injuries in child abuse. Red flags are sparing of the flexure creases due to flexion of knees and ankles at the time of forced immersion. Like if the child was forcefully immersed into the hot liquid, so there is a reflex flexion of the knees and ankles and hip. So the flexure surfaces will be spared. Sharp line of demarcation, uniform burn depth, and absence of burn in the distribution of splash marks. So these are signs of deliberate scald injury: intentional immersion, linear demarcation with no splash marks, excessive burns to back and buttocks, donut pattern, and sparing of the flexure creases like in a zebra pattern. Then we have tinea versicolor. It is most noticeable after the sun exposure as the surrounding skin becomes darker. Distribution in adults, trunk and upper extremities, and in children it is seen on the face. Tinea versicolor or pityriasis versicolor pathogenesis, it is caused by the Malcesia globosa skin flora, grows in exposure to hot and humid weather. Clinical features are hyperpigmented or mildly erythematous lesion on the face in children, trunk and upper extremities in the adolescents and adults, with or without fine scale, with or without pruritus. Stratum corneum destroy the lipid layer. What? Stratum corneum, I guess it is a destruction of the lipid layer in the stratum corneum by the Malcesia globosa, something on those lines. Diagnosis: KOH preparation shows hyphae and yeast cells in the spaghetti and meatball pattern. Treatment is topical ketoconazole, terbinafine, and selenium sulfide. Erythroderma, which is exfoliative dermatitis. It is basically exfoliative dermatitis. Symptoms are erythema and scaling in more than 90% of the body. Bright red patches coalesce and gradually peel off. So I guess this is a picture of that, and this is also a picture of erythroderma or exfoliative dermatitis. Then erythema toxicum neonatorum, that is asymptomatic, scattered blanching erythematous papules and pustules that spares the palms and soles. Pustules are sterile and contain eosinophils. It is common in full-term neonates in first 2 weeks of life and that resolves spontaneously. This is erythema toxicum neonatorum. The next thing is about tinea capitis, I guess. Yeah, that caused by the trichophyton tonsurans. Most common in USA. In the most common form is USA. In USA is the black dot tinea capitis. Most common in African Americans. Patchy alopecia with a residual black dot, that is a broken hair. Pruritus, inflammation, ocular or post auricular lymphadenopathy can also be seen. Differential ocular lymphadenopathy. What does that mean? Ocular lymphadenopathy. I don't know. I think it is auricular or post auricular lymphadenopathy because there is no lymph node in the eyeball, Nothing. Okay, differential alopecia, alopecia areata, discoid lupus erythematosus, and seborrheic dermatitis. So these are the differentials of alopecia. Firstly, alopecia areata. It is autoimmune and smooth circular areas of hair loss without scaling. Discoid lupus erythematosus, well demarcated inflammatory plaques, hypo or hyperpigmented lesions, scarring and photosensitivity. Seborrheic dermatitis involves the scalp as well as eyebrows or nasolabial folds, and it is greasy. So seborrheic dermatitis involves the scalp as well as the eyebrows and the nasolabial folds, and it is greasy to see because there is excessive sebum production. Tinea capitis epidemiology, most common in African American children, transmission via direct contact or from the fomite, that is shared combs. Clinical features are scaly erythematous patch with a hair loss on the scalp, with or without black dots in the affected area, with or without tender lymphadenopathy. Management is oral griseofulvin or terbinafine. Ketoconazole is only topical. For the nails, it's oral. Okay, so alopecia areata, it is basically there are no scales, just as patchy areas of hair loss because of autoimmune destruction. There are exclamation point hairs classic finding. So exclamation point hairs are the classical findings. Uh-huh. Narrowing of the hair shafts close to the skin surface. Okay, so they come like this and they become narrowed just close to the skin, so they look like an exclamation mark. Then the next point is about alopecia areata. The pathogenesis of alopecia areata is that it is an autoimmune attack on the hair bulb cells. There is a genetic predisposition to this one. The clinical presentation is painless, patchy, non-scarring hair loss, narrowing of the hair shafts close to the skin surface, exclamation point hairs. Sorry. Positive hair pull test, more than 5 to 6 hairs are extracted. Management is moderate, mild to moderate hair loss, topical or intralesional corticosteroids. If there is extensive hair loss, then topical immunotherapy, for example, diphenyl cyclopropanone and oral corticosteroids. In severe or widespread hair loss, alopecia totalis, we can give diphenyl cyclopropanone. Contrast with the trichotillomania, irregular growth of hairs with variable lengths. That is basically a condition in which the person pulls their hair. And intralesional corticosteroids, example are intralesional triamcinolone. Tinea corporis, it is caused by Trichophyton rubrum. Diffuse spread and refractory causes of tinea corporis should be treated with oral antifungals as second line treatment. Tinea capitis, dermatophyte infection of the scalp, always requires an oral antifungal as the first line treatment. Tinea corporis or ringworm, as you can see in this picture. Risk factors are humid environment, athletes who have skin to skin contact, and contact with the infected animals like rodents. Presentation, scaly, erythematous, pruritic patch with a centrifugal spread, subsequent central clearing with a raised annular border, and treatment is first line localized, topical antifungals, for example, clotrimazole and terbinafine. Second line extensive disease, second line or extensive therapy can be given with oral antifungals, for example, terbinafine and griseofulvin. Then we have Tinea pedis. So the etiology is Trichophyton species, most common. Clinical features are acutely can present with pruritus, burning pain, erythematous vesicles and bullae. Chronically, they can present with pruritus, erythema, interdigital scales, fissures, erosions with extensions onto the sole, side or dorsum of the foot. Treatment is with topical antifungal therapy. Keep the feet dry and dispose of the old footwear. Photo protection. Best method is sun avoidance. If you already want to go outdoors, use broad spectrum sunscreen with sun protection factor 15 to 30 degree or higher. It should be applied 15 to 30 minutes before sun exposure. What are we talking about? It is not related to the tinea pedis. It is a totally different topic. We are talking about photo protection, how to protect yourself from the sun. So we have to use sun protection factor 15 to 30 or higher. It should be applied 15 to 30 minutes before the exposure. Reapply every 2 hours, even if product says water resistant. It should be noted that cloud coverage does not block the UV rays. Sunscreen is avoided in infants less than 6 months because of the thin skin and increased surface to body weight ratio, which increases the exposure to sunscreen chemicals. However, small amount of sunscreen can be used in if sun exposure is unavoidable and additional protection is necessary. So this is what? This is keratosis pilaris. It is a benign condition characterized by the retained keratin plugs of the hair follicles. uh-huh. Presentation is small, painless papules, roughened skin texture, mottled perifollicular erythema, and exacerbations are common in cold and dry weather. It can occur anywhere in the body but is most common on the posterior surface of the upper arm. It can occur alone or in association with the atopic dermatitis and ichthyosis vulgaris as inherited disorder characterized by chronically rough scaly skin. Ichthyosis vulgaris is basically fish scales. Treatment is emollients and topical keratolytics like salicylic acid and urea. Folliculitis, it is due to inflamed hair follicles. Presentation is acute erythematous pustular eruption. Then miliaria, it is not malaria, it is miliaria. So it is also called as heat rash, pathogenesis, blockage of eccrine sweat glands in the setting of increased heat or humidity. It is most common in newborns and young children. Presentation, it can range from small, thin-walled vesicles to patches or erythematous papules or pustules. Then we have pityriasis rosacea. These are the oval lesions that come after herald patch are disturbed obliquely along the lines of tension, most noticeably on the back. Pityriasis rosacea clinical features are it is a with or without viral prodrome, annular pink herald patch on the trunk, oval lesion in the Christmas tree pattern, and pruritus. Management reassurance because of its spontaneous resolution, and treatment of pruritus, for example, with antihistamines can be given. So these are oval lesions that come after the herald patch are distributed obliquely along the lines of tension. Okay. Then pityriasis rosacea, it looks something like this. Initial sign is herald patch, like this patch, and secondary sign is a Christmas tree sign, like this is a Christmas tree pattern, like this. Yep. So the next point is about the erythema multiforme. Erythematous target lesions with a dusky center, precipitated by the infection or medication. HSV mycoplasma. Many drugs have been reported to trigger erythema multiforme, including barbiturates, non-steroidal anti-inflammatory drugs, penicillins, sulfonamides, nitrofurantoin, phenothiazines, and anticonvulsants. Then nummular eczema, chronic rash. Symptoms are dry, erythematous, and intensely pruritic patches on the extremities, like this thing. So what is it? It is nummular eczema, and this thing was erythema multiforme. Okay. The next point is about the infantile hemangioma or strawberry hemangioma. We have seen a picture of that before. So the natural history of the disease includes yeah. So natural history is that may present as patch or telangiectasia at birth. Proliferation age 0 to 1, bright red and raised nodule. Involution occurs by age 1 to 9. Deeper red-violet regression in size. Management observation. Topical beta blockers, for example, propranolol for ulcerated or cosmetically sensitive areas like face. Complications: ulceration or scarring, vision impairment if near eye, and life-threatening if it is near the airway. What is infantile hemangioma? This is something that we are talking about, and this is a new table, I guess. Natural history is that it appears days to weeks after the birth. Proliferation age 0 to 6 months. Growth of the bright red, soft, raised plaques. Involution age more than 6 months. And deep red violet lesions that regress in size. Evaluation. Clinical diagnosis. Specific consideration of more than 5 cutaneous lesion and liver ultrasound. Facial segmental echocardiography and MRI of the head, that is PHACE. What is that? I don't know. Cervicofacial, beard distribution, we have to do the laryngoscopy, and lumbosacral spinal ultrasound. So the investigations which we are supposed to do in certain areas of involvement is, if there are more than 5 cutaneous lesions, do the liver ultrasound. If there is facial or segmental involvement, echocardiography and MRI of the head is important. Cervicofacial Beard distribution, laryngoscopy is important, and for the lumbosacral involvement, do the spinal ultrasound. Management, observation for most lesions, beta blocker therapy, for example, propranolol for the high risk features, large facial segmental or rapidly growing ulceration scarring, periorbital can cause visual impairment, hepatic involvement can cause high output heart failure, and subglottic one can cause airway obstruction. Atopic dermatitis, which is also called as eczema, it is highly associated with asthma as well. Risk factors are low humidity, relatives with eczema, allergies, or asthma. Clinical features include infants. In infants, it can present with itchy, red, scaly, crusted lesions on extensor surfaces, trunk, cheeks, and scalp. Child or adult, lichenified plaques in the flexural creases. How do we treat this? Topical emollients with or without steroid ointment. Complications are eczema herpeticum, cellulitis, abscess, discomfort interfering with daily activities and sleep. Infectious complication of atopic dermatitis. So the infectious complications are impetigo, eczema herpeticum, molluscum contagiosum, and tinea corporis. What is impetigo? Impetigo can be caused by Staph aureus and Streptococcus pyogenes. The one caused by the Staph aureus is bullous impetigo. Presentation is painful, non-pruritic pustules with honey-clustered adherent coating. Eczema herpeticum, herpes simplex type 1, painful vesicular rash with punched out erosions and hemorrhagic crusting. Molluscum contagiosum, it caused by the pox virus. Flesh-colored papules with central umbilication. Tinea corporis, Trichophyton rubrum, pruritic circular patch with central clearing and raised scaly border. The next thing is about the atopic dermatitis distribution by age. So, infant, there are extensor surfaces which are more commonly involved, like the cheeks, elbows, trunk, and knees. For child or adult, flexor surfaces are more commonly involved, like the neck, antecubital fossa, the volar wrist, the popliteal fossa, and the dorsal ankles. Here you can see the child, no, yeah, it is child, and the extensor surfaces should be involved, but this is not an extensor surface. Okay, just forget about it. This is eczema herpeticum caused by the HSV1, as we have seen in this picture that uh, just give me a second. Yeah, eczema herpeticum is caused by the herpes simplex virus type 1. Moving forward, we have the next condition, that is seborrheic dermatitis. These are the greasy lesions. So the clinical feature are the peaks in infancy and adulthood, erythematous plaques and or yellow greasy scales located on the scalp, face, for example, eyebrows and eyelids, posterior ears and nasolabial folds, umbilicus and diaper area. Treatment. The first line treatment is emollients and non-medicated shampoos. Second line is topical antifungals or low potency glucocorticoids. Then the cradle cap, scaly yellow crusty plaques. Seborrheic dermatitis in an infant can be present on the scalp, which will be a cradle cap, then posterior ears, nasolabial folds, neck folds, axillae, trunk, and diaper area. The next thing is about the perianal dermatosis. So the perianal dermatosis can be contact dermatitis, candida dermatitis, or perianal streptococcus. Epidemiology. The most common cause, the what? Contact dermatitis is the most common cause of perianal dermatosis in infants. Examination, it spares the creases and skin folds. Treatment, topical barrier ointment or paste should be given. The candida dermatitis is the second most common cause of perianal dermatosis in the infants, like they cause the diaper rash, beefy red rash involving the skin folds with satellite lesions, and for that we have to give the antifungal therapy. This one spares the skin folds. The candida dermatitis involves the skin folds, and like most commonly involve the skin folds, that is called as intertrigo. Then perianal streptococcus, that happens in school-aged children. Bright, sharply demarcated erythema or perineal area, and for that we give the oral antibiotics. So this is a picture of irritant diaper dermatitis. The skin folds are spared and erythematous papules are formed. So this is basically contact dermatitis, a form of perianal dermatosis. Here you can see the candidal dermatitis. So in this, a beefy red flag is present. Rash within the skin folds and satellite lesions are also present. Like this is the lesion side, and apart from that, there is another lesion that is called a satellite lesion. So these are present like this. So this is called by the Candida albicans. The next thing is streptococcal perennial dermatitis. It looks something like this. Bright, sharply demarcated, confluent erythema in the perianal or perineal region. Symptoms are perianal pruritus, pain, particularly with stooling. Patient withholds because of pain, and that can result in constipation. Perirectal fissures, blood streaked stool. It is not necessary that the patient also gets streptococcal pharyngitis, but there may be a close contact with the recent streptococcal infection like cellulitis and pharyngitis. Then we have neonatal rashes. So, erythema toxicum neonatorum. Clinical presentation is the children will be asymptomatic and scattered erythematous plaques and papules and pustules will be present and no treatment is required. Neonatal HSV, there are three types of it. Vesicular cluster of the skin, eyes and mucous membrane, CNS infection, fulminant disseminated multi-organ disease. For this treatment, we have to look for acyclovir and staphylococcal scalded skin syndrome, fever and irritability, diffuse erythema like placid flexural blistering and positive Nikolsky sign, oxacillin, nephicillin and vancomycin. Perianal streptococcal dermatitis. So that is very blurry picture. I think I can't read this. It's too blur. No, it can't be read. So the next point is about the common insect bites. So the common insect bites are bedbug, the pediculosis, scabies, spider, tick, etc. etc. There is a side information about something. Typical reactions: painless red welts, often in group of 3, not centralized to one body part. Okay, so bedbug, pruritic small puncta and maculopapules in linear groups, breakfast, lunch, dinner pattern on unclothed skin. Okay, so breakfast, lunch, and dinner pattern, like there will be 3 lesions. So the basis of, the bites of the bed bugs, Cymex, whatever, usually follow a linear pathway in a group of 3 to 5 blood meals and are often referred to as the breakfast, lunch, and dinner sign. So firstly, they do this in the morning, then in the lunchtime, then at night. Then pediculosis, widespread itching of the hair, body, or genitalia with visible louse. Scabies, pruritic burrows or hemorrhagic crust in the intertriginous area. Spider, solitary papule pustules or wheal with or without pruritus. Tick, painless red papule with or without pruritus during the spring and summer. Okay, and some patients may have no symptoms in what? In which one? Yeah, in all of them, some patients may have no symptoms at all. Then we have Shiger's bite. Shigers are small mites that cause intensely pruritic erythematous papules on the exposed areas like ankles and waistline. Shigers are found outdoors, for example, the grassy field. Sunburn. The clinical manifestation of sunburn is symptoms begin hours after exposure and resolve by 3 to 7 days. Mild to moderate erythema and tenderness will be present. Severe, as above, with blistering systemic symptoms, for example, fever, vomiting, and headache. Treatment for the mild to moderate variant, we give the topical what? We give the topical cool compresses, clamine lotion, aloe vera, oral non-steroidal anti-inflammatory drugs. Severe hospitalization, intravenous fluids, and analgesia and wound care can be administered. The next topic is hypersensitivity reactions. So the hypersensitivity reactions are type 1, type 2, type 3, and type 4. Type 1 is IgE mediated. Examples include anaphylaxis and urticaria. Type 2 is cytotoxic. IgG and IgM autoantibody mediated. Autoimmune hemolytic anemia and Goats-Pasture syndrome are examples of that. Type 3 is immune complex mediated. Antibody antigen complex deposition, serum sickness, post streptococcal glomerulonephritis and lupus nephritis. And type 4 is the delayed type, T cell and macrophage mediated. It can cause contact dermatitis and tuberculin skin test. Okay, so this is the end of our dermatology unit, and we'll start the endocrine in the next part. Until then, Allah Hafiz, fi amanillah, and take care.